All right. Hi everyone. I will present a case from Ichilov Hospital in Tel Aviv. My name is Tzachi. I did it with the guidance of Dr. Anat Blank. The case is a 36-year-old woman, suffers from infertility, undergoing an assessment of the infertility. She has had a dysmenorrhea for 6 years and having regular menses. She has documentation of from a previous medical history chart of cystic findings in the ovaries from October 2015. She came to our institute to perform, to assess her, continue assessing her infertility. She underwent a transvaginal ultrasound, and you can see here the photos of findings in the left ovary and the findings in the right ovary. And my first question will be, what are the findings in the ovaries? Are these follicles, corpus luteum, endometriomas, or ovarian malignancy? 20 seconds, that's all. All right, you're right. Endometriomas. That's a very classic. Classic view of the endometriomas, as we saw many times in lectures earlier today. The rest of the examination here, we can see the uterus. This is the uterine cavity, and note that cystic lesions here in the posterior myometrium. We will address them later. This is a longitudinal view. Here we can see the uterine cervix and the rectum, and between them we can see an irregular hypoechoic lesion with irregular borders. And my second question will be, what do you think this is? Is this a metastasis? Is this an endometriotic implant? Is this a duplication cyst or a diverticulum? All right, right again. This is an endometriotic implant between the uterine cervix and the rectum. Now my next question will be, what will be your next step in the assessment? Will it be a follow-up ultrasound? Will it be MRI? Will it be a CT or none of the above? Right again. The next step will be an abdominal and pelvic MRI. So these are the MRI photos. We can see here in the photos above this T1 sequences with and without fat set. We can clearly see the endometriomas. Here you can see a very bright, very high signal on T1. And those are the T2 images, lower signal, T2 images with and without fat set. Lower signal of the endometriomas on T2. We can see the endometriotic implant here. We're about to see a better picture of it. Note the high signal lesion in the posterior myometrium. We will get to it later. Those are sagittal views of the T2 sequences. Here we can see very clearly the endometriotic implant. Bowing of the rectum, tethering of the uterus, thickening of the ligaments, and some high signal foci inside. Here, the same lesion after contrast enhancement. We'll see this picture again later. And my last question is, regarding to the high signal lesion that we saw in the myometrium, what do you think it is? Is this a cyst, a leiomyoma, an adenomyosis, or endometrial carcinoma? Okay, and you're correct. Adenomyosis, we've already seen that adenomyosis and endometriosis are actually the same, the two sides of the same condition. Very high correlation between the two. We'll briefly go through endometriosis. I won't be long about it. 80% of the patients are premenopausal, ages 24 to 40. 10% are adolescent and 20% are postmenopausal. It is more prevalent among the Asian population and in higher socioeconomic groups. It improves during pregnancy and menopause. Its size may increase with menses. It is self-limiting in most patients. And we have endometriosis malignancy in about 1% of the cases. The signs and symptoms are numerous: dysmenorrhea, pain, dyspareunia, and many other, but a large percentage are asymptomatic, and the symptoms may be cyclical due to varying estrogen levels. The modality of choice, as we already seen for diagnosing of endometriosis, is transvaginal ultrasound. We do use MRI because it is most sensitive for deep infiltrating endometriosis and allows a more accurate preoperative planning, as we saw earlier. There are three types of pelvic endometriosis, three subtypes of pelvic endometriosis. One is the ovarian endometrioma that we have seen in the beginning. It is a very obvious finding to diagnose on imaging. The second is deep infiltrating endometriosis, or DIE. I will shortly elaborate about it now. And the third is superficial peritoneal lesions, which are rarely seen on imaging. The findings that we see on ultrasound of peritoneal plaque of DIE are hypoechoic solid lesions that has irregular shape and indistinct margins, like the one we saw before. It can have multiple bright foci, small cystic areas. The sensitivity of ultrasound for diagnosing DIE is about 78%. Another typical finding that we can see on ultrasound regarding endometriosis are the kissing ovaries due to adhesions that cause proximity of the ovaries to the uterus and one to each other. Here we have two examples. Those are two ovaries. The right one has endometrioma in it. You can see a very classic finding. And those are two normal appearing ovaries that kiss each other. What we'll see on MRI, we'll see the plaque will be iso-intense muscle on T1, iso-intense also on T2, and it can have hypo-intense nodules that reflect fibrosis. After contrast enhancement, it will be hypovascular and have delayed enhancement. We have low signal spiculated bands on T1 and T2. We can see angulated tethered bowel ovaries on both T1 and T2, and obliteration of organ interfaces. There are several subtypes of DIE. I will shortly address some of them. One is retrocervical. It can look as diffuse or focal thickening of the uterosacral ligament. It can have stellate nodules at cervical insertion, and it can have soft tissue along the posterior uterine serosal surface extending from fundus to cervix. I will show again the example I showed before. This is a very good example of retrocervical endometriosis that have the features that we discussed. GI tract endometriosis, most of them are in the anterior rectum or rectosigmoid colon. The implants are usually superficial, invading the serosa, but can extend to muscularis propria and submucosa. Implants typically are along the antimesenteric border. Solid homogeneous nodules with irregular, it looks like solid homogeneous nodules with irregular margins that are hypoechoic on ultrasound and have a low signal on T2. Distinct feature is the pyramidal shape of the nodules. It's based at the anterior rectal wall and its apex at the retrocervical region. Here we can see an example of an endometriotic implant in the iliacecal valve region. And here are the example of the pyramidal shape nodule here on T1 and here on T2. You can see a very distinct, very classic shape. The last subtype I will shortly discuss is the urinary tract DIE. It is most commonly involves the urinary bladder. It causes the full thickness infiltration of the distrusal muscle. It can look as a mural mass projecting into lumen with intact overlaying mucosa. It is usually midline along posterior bladder dome. Its subperitoneal location of the implants may limit the visualization during laparoscopy. And last thing, that ureteral involvement is rather uncommon. Here we can see an example of such an implant. You can see it on the bladder dome from top. This is a T2 sequence without fat set, and this is a T2 with fat set without contrast enhancement. This is what it looks like. Thank you very much.